Thank you, Dr. Yacoub and the organizers. I really appreciate the opportunity to come out. I know Nassir regrets the opportunity not to be able to come out, but I consider that his loss and my gain. So today, I really have to acknowledge Nassir for all this work, or I wouldn't be here today, for the substrate guided management of AFib. And we'll get started here. These are my disclosures. So as Sabine mentioned, there's been a lot of work that has elucidated our understanding of AF mechanisms in the past 15 years. And we can see here, we've evolved from thinking of rotors, mother and daughter rotors, to pulmonary vein triggers, SVC triggers, appendage triggers, as well as the ganglionated plexi here and the ligament marshal, all serving as triggers for AFib. And as Sanjeev has shown us recently, he's been able to map rotors, and I think really given us a paradigm shift in terms of thinking AFib is not necessarily a left atrial disease, but it can originate from both left and right atrium. You can see a left atrial rotor here, and then also a right atrial rotor here. And with targeting these rotors, you can get a beautiful conversion to sinus rhythm here, and a very gratifying ablation here. And I think some very exciting results will come from the randomized trials that's looking at rotor ablation plus or minus pulmonary vein isolation in these patients. But when I look at AFib ablation results, I'm always a little bit discouraged with long-term results. And these are four very reputable, high-volume centers. And if you look at the long-term results, with a single ablation, I think the common theme here is we really don't get better than 40 to 60% success rate. And another common thing that you can take away from all these data is that a significant amount of the population self-selects itself from the AFib ablation results. So you can see here within the first 3 to 6 months of all this data, there's about 40 to 60% of patients who don't show any long-term benefit. And why is that the case? Well, I think in Nassir things, we both think that it's partly due to the atrial substrate. This goes back to data from Dr. Alessi and colleagues, where AFib is not necessarily just a heart rhythm abnormality, but you also see structural abnormalities, like you see myolysis here, dedifferentiation of the atrial myocardium, abnormalities of connexin expression, as well as loss of connexins, and ultrastructural changes, which we all think serve to create a substrate for atrial fibrillation. If you take this one step further, one of my mentors, Jeff Hogan, has looked at a transgenic mouse model for AFib. And in this model, mice are notoriously difficult to induce and maintain AFib. And if you look at the wild type mouse here, very beautiful right atrial, left atrial myocardium free of fibrosis, and very aggressive stimulation to induce non-sustained atrial fibrillation. In this transgenic mouse model, they were able to induce selective atrial fibrosis, and you can see here the extensive right atrial and left atrial fibrosis. And the common theme of all these transgenic mice was they were very easily inducible for AF. They had a very heterogeneous conduction pattern in the atrium, and the epicardial conduction velocity in these mice were very slow, thus serving, I think, to create the link between AFib and atrial fibrosis. One of my mentors has always told me, as an EP, your best friend will be a cardiac surgeon. And so I picked the brains of my cardiac surgeons and looked at mitral valve surgery and AF patients. And you can see here, in this mitral valve repair patient, a very nice pattern of smooth, organized atrial myocardium here, free of any fibrosis, and this patient had no AF. You look at these two patients here, both mitral valve surgery patients, both with a history of AF, and you can see the disorganization created by these fibrosis patterns. And you take this one step further, and you look at the successful maze patient, you still have preservation somewhat of the atrial myocardium here, but in the failed maze patient, again, you see dedifferentiation, myolysis, and a very dense fibrotic pattern here. So if we can't always do atrial biopsy samples and screen these patients with biopsy, so we look to go with MRI as the next step and try and identify these patients. And what we've done is use MRI to guide our atrial disease assessment. We're also using it to help guide us in terms of stroke risk. Is a novel use of it. And we're also using it to personalize arrhythmia therapies, and we'll get more into that as well. This is how we detect atrial fibrosis. This is the axial MRI scan here. Sorry. So this is the axial MRI scan here, and you can see the delayed enhancement in the left atrial wall here. We are able to, sorry.
Read the mouse, try to.
Yeah. So I'll just go with the mouse. So you can see the atrial fibrosis here represented in green, and with a 3D reconstruction, normal healthy myocardium is represented in blue, and you can see the atrial fibrosis pattern here in green. Now everybody, we use a manual thresholding algorithm for this, and everybody says, well, how can you tell green is really fibrosis? And so what we've done here is we have, again, gone back to the operating room, taken biopsy samples of patients randomly selected based on their fibrosis score, and directed our surgeon to help us with these biopsies. So in this patient who has a very healthy left atrium here, minimal fibrosis in this area, you can tell, again, a nice, healthy, organized atrial myocardial pattern here. And in this subtraction histology slide, the absence of myocardium is just a fibrosis pattern. You look here in this patient, and this biopsy sample was done in the border zone of the fibrotic area. You can tell more dense fibrosis, but still a organized pattern of atrial myocardium here with the interspersed fibrosis here. And then here we take a patient who had dense left atrial fibrosis, taking the biopsy from right in the middle of that fibrotic region. And again, the recurrent pattern, dedifferentiation, myolysis, and a dense fibrotic pattern here, creating what we believe is a substrate for AFib. And so then we've also gone on to further characterize these patients and stratify them into the Utah stage 1, stage 2, stage 3, and stage 4 based on the fibrosis score. Stage 4 being greater than 30%, stage 1 being 0 to 10%. We'll come back to that, but to take it to the next step, we wanted to see what is the effect of our ablation lesions, and can we detect ablation scar? So to pick a different color, we use red here to detect our ablations, to depict ablation scar. And all these post-ablation MRIs are done at least 3 months post-ablation to represent chronic scar. And you can see here the dense scar pattern represented in this left atrium as red and white. We've gone the next step and tried to look at our recurrences, and can we detect a difference in ablation scar in these patients? And in this patient here, this was very eye-opening for us in terms of, we see this, as Sabine had illustrated, the nice Hamburg approach of isolating the pulmonary veins. And we have nice scar here, but nothing along the anterior wall. And this is pretty humbling. And you really have to accept this and learn from this. And you look at our lasso in the left superior pulmonary vein, and it correlates with a reconnection of the left superior pulmonary vein to the left atrium, and the left superior pulmonary vein tachycardia that had triggered AFib. This has gone on to extend to some other investigators. They've also looked at a reconstruction of the left atrium, red being chronic ablation injury, and yellow being the areas of absence of ablation injury. And they've named this reversible injury. And the greater the area of reversible injury in this study correlated with a higher rate of AF occurrence in these patients. Thus illustrating you really have to do a good job with your ablation lesions to get that scar. So this led Nassir and my other partners to proceed with the DECAAF study. And it stands for Delayed Enhancement MRI Determinant Successful Catheter Ablation of AFib. And what we looked at was the degree of left atrial fibrosis detected with DE-MRI affects the response to AF ablation. We also looked at whether or not the site of the ablation lesions predicted the affect the procedural outcome. And this was a prospective, multi-center, blinded follow-up study. These are the various sites that were participants in the study, and as you can see here, 6 in the US, 8 in Europe, and 1 in Australia. All these centers performed a pre and at least a 3-month post-ablation MRI. The MRIs were sent to the core MRI lab at Utah, where they processed all the MRIs blinded to the investigators. So in this study, we screened 329 patients. We excluded 57 because of poor quality pre-ablation MRIs. And then of those patients who had a usable pre-ablation MRI, 96% completed follow-up here. This is data that mirrored our single center results here, and again depicting that stage 1 patients had the best outcome with ablation, irrespective of the ablation strategy. This was left up to the investigator. Stage 4 patients had the poorest response to ablation therapy, and stage 2 and stage 3 patients, again, ranging at 54 to 64%. When we looked at the three-month post-ablation MRI for these patients and looked at scar, one of the surprising findings for the other co-investigators in the study was about 39% of patients had absence of complete pulmonary vein encirclement. And this was tough for a lot of other investigators to accept as well. And then if you look at how many veins were completely encircled, the minority of patients had all 4 pulmonary veins encircled. And you can see another 44-45% of patients had only 1 to 2 pulmonary veins completely encircled by ablation scar. One of the things that has also been interesting to us is the amount of residual fibrosis. And what we mean by that is we look at the pre-ablation fibrosis score and quantification here. We look at the post-ablation scar, and we subtract this scar from this, and we get a quantification of our residual fibrosis. And when we looked at this and grouped them into quartiles, patients who had a minimal residual fibrosis score, the best in terms of ablation outcome. Again, the patients who had the more residual fibrosis, or greatest residual fibrosis, had the worst outcome to ablation. And again, the middle 2 groups had a moderate success rate. And so this is kind of fed into our theory that possibly targeting the atrial fibrosis with ablation may be one of the keys to improving upon the success rates for stage 2, stage 3 patients. We're hesitating to do that for stage 4 patients. But this is one of the approaches we're taking now with ablation of the left atrial posterior wall and the anterior septum. This is data that's just been recently published by our group and something we've been very interested in. And it's looking at the association of left atrial fibrosis and the risk of stroke. These are 3 patients. All 3 patients had a CHAS-2 score of 2. All these patients came from a cohort of 178 patients who had both a TEE and a pre-cardioversion or pre-ablation MRI. And we quantified their atrial fibrosis and correlated that to their TEE findings. And in this cohort, we had 12 patients who had a left atrial appendage thrombus, another 17 patients who had spontaneous echo contrast, and looked at the relationship of left atrial fibrosis to the TEE findings. And we can see here, patients who had a normal appendage, no spontaneous echo contrast, had a mean fibrosis score of 16.7%. With spontaneous echo contrast, the mean fibrosis score here is 23%, and appendage thrombus patients had a mean fibrosis score of about 27%. This is a retrospective analysis, but we're moving forward and looking at some other mediators of inflammatory markers, prothrombotic markers, as a prospective study to follow up on this. So for our personalized treatment algorithm of AFib, what we're looking at now is pretty much a pre-ablation screening MRI for all of our AFib patients. And if the patient chooses to pursue a rhythm control approach, we've been recommending ablation as a first-line therapy, or if they failed previous antiarrhythmic drugs for Utah 1 and Utah 2 patients. For Utah 4 patients, right now we're favoring medical management and sometimes even a PACE and ablate approach. And Utah 3 patients, we've been categorizing further into patients with localized fibrosis or diffuse fibrosis. If patients have localized fibrosis, we'll pursue ablation in these patients with the goal of achieving pulmonary vein isolation as well as targeted ablation at the fibrosis regions. And for those patients with diffuse fibrosis, we've been favoring medical management. And so in summary, we believe that atrial disease and atrial fibrosis can be reliably detected and quantified with MRI. We believe that MRI-guided atrial disease detection can be used to personalize AFib therapy, one in terms of individualized ablation strategies, and two in terms of potential stroke risk quantification. And three, in the DECAAF study, we found that a lower residual atrial fibrosis burden was associated with improved ablation outcomes, and something we'll be trying to expand upon in DECAAF2 in the future. And this work would not have been possible without the work of and assistance of my colleagues here in the CARMA team. And thank you.